Thank you. Thank you. Great to be back speaking at the Texas Heart Institute, which is, of course, my great love. I've been here since last century and I've loved every day of it. So innovation, very simple topic, but a very important one, particularly for this institution. The Texas Heart Institute has a rich history in innovation. Most of that, I would say, is a direct result of Dr. Frazier, who's in the audience, and Dr. Cooley. Some disclosures. So the innovations I'll talk about, most of them are of my invention, and thus I have a financial interest in them, though all of the innovations are in various stages of research and are not commercial products yet. So Procerian, I'm a founder and owner of, and Naxium, I'm a founder and owner of. Bivacor, I do not have a financial interest in. So that's my disclosures. So how do we innovate? I was taught a long time ago by a venture capitalist, a very prominent one, that the very first thing you do when you plan to innovate is start with the problem. So don't come up with an innovation, come up with a problem you want to solve. That's the first step. And the entrepreneurs call this a needs assessment. The problem needs to be something that's real, that is societal need. And it needs to be something that you think you have some domain expertise in, so you know something about this problem. Next, you disbelieve what you know about the problem, and that's key to innovation. There is this concept of dogmatic versus empiric thought, and dogmatic thought is what you do every day. In the care of patients, you apply evidence-based thought to the care of patients, following guidelines, very dogmatic in your approach. So all of you are experts at dogmatic thought, but that means you're not experts at empiric thought, because that's really the opposite. And so empiric thought is thought without evidence. So the ultimate in empiric thinkers would be the Greek philosophers who did thought experiments to solve problems with no evidence. And so you got to switch your mindset from dogmatic thinking to empiric thinking, and that's how you disbelieve what you know about the problem. From there, you free associate different approaches. And I would suggest that you start with the opposite of dogma. There are many examples in medicine where the opposite of dogma ended up being a real solution. Just one example would be when I first started residency, it was dogma to not use beta blockers in heart failure. You don't give any medicines that decrease cardiac output in heart failure. And now, of course, the dogma is the opposite of that. Early in my career, the dogma in treating cancer was to suppress the immune system by various means. And now, of course, the dogma in the newest treatments of cancer is to augment the immune system. So there are lots of examples where dogma is turned on its axis. So once you've done that and you've come up with some concepts in your mind, then you craft your thoughts. And by crafting your thoughts, you mold it into something that makes some sense and use nature to inform. Nature has done all of this in some way, shape, or form. You just have to look hard enough and you'll find it. For example, we'll be median arcuate ligament syndrome for weight loss, which we'll get into. Always apply the KISS principle. The KISS principle stands for keep it simple and stupid. Keep it simple and stupid. And we'll discuss that in a minute. And then finally, use established predicates. Most of what you will innovate and develop has some basis of it that's established in a predicate in some way, shape, or form. Maybe not even in medicine, but in other fields of study like engineering or oil field mechanics, or, use established predicates. How do you free associate? Well, it's a mental process by which one word or image may spontaneously suggest another without any apparent connection. So it's the expression of content of consciousness without censorship. That's key, without censorship, as an aid to gaining access to unconscious processes. So censorship is what you're taught in medical school and residency. You're taught what you can't do. And so you have to disassociate yourself from that. This is David Byrne, a singer-songwriter of the Talking Heads. He has this great quote here. I use stream of consciousness approach. If you don't censor yourself, you end up with what you're most concerned about, but you haven't filtered it through your conscious mind, and then you craft it. Really neat quote. All right, so let's get into some of the innovations. So first, I'll start with Procerion. This is one of the companies that I founded, so I have a financial interest in it. So the device itself, just for so you can conceptualize in your mind, is as big as a crayon, size of a crayon, very simple. So I started with a problem. So what was the problem I was solving here? The problem is all of the problems associated with VADS. Okay, so you only need to take a walk on 25 Tower, 8 Coulier B to see all the problems associated with VADS. So stroke, infection, right heart failure, bleeding, the fact that they are a major surgery, and the fact that they don't really promote recovery well. These are the problems. So you start with the problem. Who are we going to apply it to? Well, we need to apply it to less sick patients. So equipoise only allows us to apply current day VADS to the very sickest of the sick. Those patients that are NYHA class 4, failures of inotropic therapy, usually on some other bridge device, short-term device. So these are the sickest of the sick. And equipoise only really allows us to apply it to them because it is a major open heart surgery. But if you have a technology that is kinder and gentler, a lesser procedure, less invasive, then equipoise will allow you to apply it to the less sick patients and therefore prevent those patients from progressing into class 4 heart failure and thus all the bad outcomes. These are some of the early renderings of Procerion device. In the descending aorta, a rotary pump device with metallic struts that anchor it into the aorta. And then a drive line that passes through the arterial wall and externalizes or is connected to a transcutaneous energy transmission system. Long-term usage was conceptualized initially, and implant in the cath lab, and the ability to have it replaceable, kind of like we explant IVC filters. So some problems with current devices, there's the concept of parallel pumping versus series pumping. So pumping in parallel, 2 pumps pumping in parallel, cannot accurately simulate normal systemic flow and perfusion of all the vascular beds, creation of competitive flow, creation of a high afterload in the aortic root. That's parallel pumping, and current LVADs do that to some degree. So what we really need to do is pump in series, and pumping in series is more natural, more physiologic. And so decompressing or unloading the ventricle at the aortic root, at the base of the heart, rather than at its apex. Now, the concept of fluid entrainment is key to the Procerion device. Fluid entrainment is a physics principle wherein a narrow jet of high flow creates a low pressure adjacent to it, which then entrains low flow fluid. And so therefore, you're pulling along or bringing along the low flow fluids into the high flow jet. It's the concept by which lazy rivers work, have a bunch of high flow jets pointing in direction of flow. and therefore creating a net increase in total flow. It's the concept of the Dyson fan. So the Dyson fan has these high flow jets at the perimeter, the rim of this. And those high flow jets then entrain the air that's flowing through the middle of it, and also the air that's incident on the side of it through this viscous shearing and low pressure creation. And it's also a concept of airfoil lift in airplanes. And so a low flow creation at the top of the wings, creating lift to bring the plane up. And so early on, we did CFD modeling. So this is computer flow dynamics modeling of the effect of the Procerian device in the descending aorta on the LV. And so as you increase the DP, or the change in pressure, by increasing the pump speed, you decrease LV EDP, LV systolic pressures in the ventricle. Remember, you're in a closed system here. And so the entrainment, so the pump, the Procerian pump, which is known as the aortics, utilizes the entrainment concept, the jet pumping, to increase flow without the use of valves or other design elements. So one moving part. So blood enters the inlet, exits the outlet, and there's energy transfer between the outlet and native flow via entrainment that increases total cardiac output. And so afterload from the heart is decreased at the aortic root, again at the base of the heart. The work of the heart is diminished. Some of the work of the heart is done by the pump, and the ejection fraction and cardiac outputs improve roughly 15% in the animal studies. And then, of course, because the pump sits right above the renal arteries, the renal perfusion is increased by a substantial amount. It sits in the descending aorta, the concept being that you're in a closed system, so you could theoretically put it anywhere in the system to do its work. And by putting in the descending aorta, you decrease risk of thromboembolic events to the carotids, and therefore stroke risk is minimized. Just early animal studies showing pressure volume loops and these beneficial movement of the pressure volume loop to the left and down, and also in hemodynamics and some of the early animal studies with improvements in cardiac output, decrease in EDP and stroke work, and elastance improving. Renal blood flow, both flow and pressure improve. In the animal studies, a 36% increase in flow and a 58% increase in pressure at the renal bed. So you can imagine this helps to turn off the augmented renin-angiotensin system that is present in chronic heart failure, and therefore can lead to a downregulation in those neurohormones in a beneficial way. This is the very early renderings of the initial strut systems dating back a decade or so. And some of the very early animal studies that I did here in this lab showing sheep with a baseline cardiac output about 4.5. You turn on the device, you turn it up to 2.5 liters a minute, and cardiac outputs go up over 6. And then taking simulated heart failure in sheep by applying esmolol drip to them. So initially their cardiac output's 5. Then you turn on the esmolol, it goes down to around 3.2. And then you turn the pump on and then normalize their cardiac output. Just kind of proof of concept. So state of Procerian as it stands now. A pilot study has been completed in the United States, 18 patients in this pilot study with a 5-day usage and inpatients. So this is cardiorenal syndrome, acute decompensated heart failure. Cardiorenal syndrome, acute decompensated heart failure. So these are patients who are failed standard medical therapy and have worsening renal function. And so all 18 patients had renal parameter improvement. All 18 patients had significant decongestion. Some of them was very dramatic decongestion. All but one patient had hemodynamic improvement in those hemodynamic parameters we talked about. That one patient has pulmonary hypertension, had a PVR 7.3, so was probably inappropriately enrolled in the study with pulmonary hypertension, group 1 pulmonary hypertension. There were no strokes or emboli. There was some groin bleeding complications, and from a 15 French system, you would imagine that. So that's the state of the pilot study that was just finished. The future is the pivotal trial is going to start in about 3 months. It's going to be 180 patients, multi-center, multiple hospitals, including the Methodist next door. Next on that will be a follow-on study in 2024 for the chronic device. So the chronic device will be an outpatient take-home device. It will be TET powered with no transcutaneous elements, drawing approximately 1 watt continuous. It will be of a smaller French size. It has been tested out to 140 days in animal studies with no failure or thrombosis, and has been tested with prolonged on and off periods. So in case they have an interruption of power, it's been tested to have the ability to be turned off days passing and then turn it back on with no thrombosis and no restart problems. There's also an ongoing study in which the device is being given to high-risk heart surgery patients who have renal insufficiency, and it's being started preventatively to prevent renal failure in high-risk heart surgery. That's a separate study that's being done. Just a point to be made is the device does not have a purge system. The bearings are washed by entrainment of blood flow, and therefore there's no purge system needed as with the Impella. Took a long time for the company to come up with the motor concept that would allow that, but this motor seems to be durable and like I said, has been tested out to 140 days. Alternative devices, there's not a lot known about the Impella BTR device, but this is what is publicly available on that device. The Impella BTR, or Bridge to Recovery device, is a forward flow heart pump that is implanted via the axillary artery via vascular surgery. It sits in the LV, crosses the aortic valve, outflow goes into the axillary artery via a vascular graft anastomosis at the right subclavian. It is a bridge to recovery concept and an adjunct to other therapies in class 3-4 heart failure. The vision is to provide a patient with home discharge more than 1 year of full hemodynamic support. It does require a purge. It does require a transcutaneous drive line. So there's a flush line and a wire exiting the body, and it's put in via vascular surgery. There's a device known as the second heart device. This is another alternative that's being developed out there. And I think the way to conceive of this device is if the Procerian device is a jet engine, this is a prop engine, propeller engine. And so the device is deployed with the propellers folded back. And then once deployed and anchored in the aorta with a strut system, the propellers deploy and then are spun on a cabling system. So the cabling system exits the body and has an external motor that spins the cable. The cable transits through the catheter and spins the rotor, the rotor, yeah. And so this, you can imagine, is only meant as a short-term device and requires patient to be supine at bed rest. Similar in concept to the original hemopump, which was first studied by Dr. Fraser here. in that it's got the external cable drive system, but different in that it has a rotor that is like a propeller. So this is being studied as well. Also, it is meant to sit in the descending aorta in the same location as the posterior aortics. Okay, so let's get on to the Bivacor. So I do not have any financial interest in Bivacor. The inventor is in this room, Dr. Fraser. And backstory, of course, we all know the backstory. The original artificial heart by Drs. Cooley and DeBakey. And while DeBakey was getting funding for the artificial heart program, Cooley implanted the first, leading to the bitter feud. And the development of that device went on through many iterations, ultimately becoming the Leonomatic heart, and then the Jarvik 7 and CardioWest and Symbion, and then ultimately the SynCardia total artificial heart device, of which there have been over 1,600 patients implanted with around a 60% one-year survival. This is a driver, the Freedom driver, for which they could leave the hospital. And this device is no longer manufactured. It had a number of problems. There was the survival rate, which was 60% at 1 year, limited durability. Freedom drivers went out a lot. Transcutaneous conduits were large. Infection risk was substantial. Thrombosis risk was substantial. It also had this problem of decreasing red cell survival time. Therefore, patients necessitated frequent transfusions, and this made them difficult to transplant because they had antibody production. So for a lot of reasons, this device was no longer used. The Abicor total artificial heart was studied primarily here by Dr. Fraser, and was an Abiomed device, very complex, very cool device, actually had TET power. And after over 150 animal implants, there were 14 human implants around 20 years ago. 5 of those were here at THI. I took part in that endeavor as well. And longest survival, 15 months. Only 4 patients lived longer than 9 months. Lots of multi-organ failure, infection, death from strokes. Also recognizing that these patients were only approved to be in the trial if they had an estimated 30-day mortality of 50%. So these were really sick patients going into the study. So in that way, to some degree, the device was very hamstrung. But despite that, the device did get FDA approval, though was not pursued by Abiomed Corporation. Abicor, it was too big. It consumed too much power. It was challenging to maintain the circulation right and balancing pulmonary systemic, limited durability, and strokes were a significant problem. Carheart device, a French device that is, as you can see, somewhat complex and big. 5 patients implanted, longest survivor, 8.5 months, also had similar problems, multi-organ failure, postoperative complications. So the future of the artificial heart, remember the KISS principle, keep it simple and stupid, meaning idiot-proof, right? So Dr. Billy Cohn has made a corollary to that concept. Just when you think you made it idiot-proof, they find a better idiot. It is so important to keep these concepts simple. And that means minimal moving parts, minimal moving parts. Now, the LVADs have one moving part, a spinning rotor. And so why not take an LVAD, or better yet, 2 LVADs, and create a TAH out of that, 2 moving parts. And so, of course, Dr. Fraser conceived of that wonderful idea, utilizing the KISS principle, and initially 2 Jarviks in animals, side by side, one for the right, one for the left. And then ultimately creating a TAH for animals, then going on to use a DeBakey micromed pump. And then there were problems with the inflow, getting the inflow right and simulating atria. And so our resident MacGyver, also known as Billy Cohn, went to his medical device prototyping headquarters and got some drywall repair fabric and caulking glue and fashioned what became the inflow canyon or conduits. And those were then attached to the DeBakey micromeds for further animal studies. Again, with the heart removed. So this was a total artificial heart. And there you can see Dr. Frazier feeding molasses to one of the calves. And then we went on to use the HeartMate 2 devices. And this was then actually done by Doctors Frazier and Cohn in a human. This patient who had amyloid received this device, which was made of 2 HeartMate 2s. He survived for 5 weeks on the device, succumbed to essentially hepatic failure. Again, he had amyloid and had hepatic disease from that. Doctors Frazier and Cohn did a TED-Med talk on it. It was in National Geographic and the cover of Popular Science. So along comes Daniel Timms, who's a very talented engineer from Australia who was tasked with the concept of making it even more simple. So not 2 moving parts, 1. Let's do it with 1 moving part. And so along comes the Bivacor. So the Bivacor has that 1 spinning rotor you see there. And the rotor has stators on it, which are of different design from each other. The stators on the left side pump to the left circulation, stators on the right side pump to the right circulation. And because they are of different design, they are optimized for optimization of flow versus pressure. As you know, flow is higher on the right and pressure is less on the right. So creating that optimization by ingeniously designing the stators of the rotor. And so that was Daniel Timms. And having the ability to make this device 3D printable, the original devices used in animals were plastic and they were 3D printed. The rotor itself is ferromagnetic and spins on a magnetic field. So it's magnetically levitated with a very tiny gap. But you can imagine that gap on that rotor then is a source of shunt, and it is on purpose. You can see the size compared to the old Abiacor device and hemolysis studies, inflow cannulas, designing inflow and outflow cannulas and flow meters, and of course, many animal studies later, including the concept of needing a pulse or not. The device was designed to deliver a pulse. And it is, we believe, important to have some pulse, the pulse pressure of which is still not clearly understood. But the device can create a pulse. As you see here, creating a pulse pressure in the 35 to 40 range. This device can max out at 23 liters a minute, so it can really pump a lot. For the animals, 10 on each side, pulsatile if desired, autonomous moment-to-moment balancing of the rotor from left to right flow by moving ever so slightly more towards the left or the right. in order to balance flow on those two sides to allow for balancing of flow and pressure, right-sided circulation versus left. It's small, 6 by 6 centimeters. The blood gaps allow for the left to right shunting on purpose, which is mitigated by increased overall total flow. The plastic then became titanium, and the titanium is 3D printed for the follow-on animal studies, of which many have been done, and the required amount have been completed so that we can now move on to human trials. Suffice it to say, many animals have been treated with this technology. This last slide here is poignant, as that is Dr. DeBakey and Dr. Cooley there, watching one of the animal studies of this device. The state of the Bivacor, the animal studies have been completed. The FIM, or first in man, is expected in September. It is likely the FIM will be here in this institution. There are other institutions vying for that, but it's likely it'll be here. Initially, this is going to be for checkmate patients. So primary graft dysfunction, severe rejection post-transplant, giant cell myocarditis, massive MIs, patients on biventricular support with no other with reasonable organ function who can't be weaned, real checkmate patients. All right, let's talk about our third innovation. Third innovation, and this one's interesting because it really is informed by nature. Anaxium. So Anaxium, again, this is of my concept, and so I have a conflict in this. Was formed back 5-ish years ago. The predicate in nature is MALS, median arcuate ligament syndrome. This is a syndrome of young men going through their growth spurt who have their celiac origin caught up in the median arcuate ligament of the diaphragm and occluded. And so their celiac origin is occluded. And so they get weight loss, food fear, and early satiety. Now, as you remember from anatomy, the celiac artery is heavily collateralized to the superior mesenteric artery. So you can sacrifice, even acutely, celiac flow without having infarct or ischemic complications in humans. And this sometimes happens in trauma, also in aortic surgeries and aortic stenting. Sometimes the celiac is sacrificed. And so the concept is of essentially jailing the origin of celiac with a mesh made out of a material that promotes ingrowth of cellular elements, therefore slowly and partially occluding the celiac. A stent deliverable device that covers the celiac but not the SMA, made of laser cut fabric and promoting a slow ingrowth. It is placed in such a way that there are radiopaque markers to know the origin of the celiac so that you can go and open it if you need to. So it's reversible, resulting in early satiety and weight loss, and simulating MALS. And just some animal studies early on done in the animal lab. So the study is initially for patients who have morbid obesity as such that they are literally dying. So that would be heart failure. It would be perhaps severe coronary disease in need of a bypass surgery, but can't undergo that because of obesity. So that's our initial concept of utilization of this. And so we did first in man in Paraguay. That's Dr. Cohn. And you probably recognize Joggy George there in the middle of the frame. Standing behind him is Swanko Krazier. And so they went down to Paraguay, and we did 2 humans down there in October of last year. And we now have long-term 120-day follow-up of those. The first patient has lost 15 pounds, has had a reduction. She has heart failure. She had a reduction in blood pressure, no adverse events, no pain. She does experience some discomfort, she says, when she eats too much. The second patient has lost 31 pounds, no adverse events. She does feel pain if she overeats. I feel much better these days, quote unquote. Okay, so these are just 3 examples of innovation. I'll go back to this innovation slide to kind of come back to the overall concept. So first, start with the problem and identify the problem that you feel passionate about, that you feel there is a true need, a need in your society, in your community, in your patient population. Disbelieve what you know about the problem. Use empiric versus dogmatic thought in conceiving your approach. Perhaps use an opposite of dogma approach in conceiving your thought. Craft those thoughts into something practical, usable, informed by nature, if possible. And always use the KISS principle. Keep it simple. And use established predicates when you go to develop the device and create the prototypes. The imperative of innovation, well, innovation is the quote unquote new research. Basic science is incredibly important, of course, but often not practical for clinical cardiologists. Innovation, I would say, is practical for clinical cardiologists. There are a number of examples. Mehdi Rezavi, Emerson Perrin, Krazier, Dr. George, myself, and others. So it can be done by clinical cardiologists. And it is a way to move fields forward. So it's very translational. So it can truly move fields forward in the hopes that you can move mechanical support forward in such a way that it's kindler and gentler, and that could benefit generations of patients going forward. So the possibility to improve morbidity and mortality in generations is really there. Also, I would say that the ecosystem for doing innovation in Houston uniquely is very, very good. In fact, I believe it's the best in the world for medical innovation. This is just 2 examples of that. The TMCX is about a mile from here. The origins of Procerian were there. It is an incubator that starts up around 50 companies per year. It is completely funded by the Texas Medical Center Foundation. Essentially, if you have a good idea and you apply to be a fellow in this program, they will supply the rest. They will bring on the entrepreneurs, the business people, the IP expertise, the prototyping lab, whatever you need. Next to that is J Labs. Procerian also had a fellowship at J Labs. J Labs is just next door to TMCX. And the J Labs has full prototyping units over there. And I didn't put it on here. I should have included a slide on Dr. Cohn's lab, which is next door to that. Dr. Cohn's lab is one of the best prototyping labs in the world. They can 3D print in titanium. It has a 3D VR suite that you can use to render your devices in 3D and VR. So lots of capability and a great ecosystem for innovation here. My greatest thanks to Doctors Fraser and Cohn. That is it.